Okay, good morning, everyone. Again, to the organizers, thank you very much for inviting me to here. I really enjoy this meeting whenever I come, and I'm glad to be part of the meeting. So today, my topic is anatomy of TGA. I added a few more words in 15 minutes. What I need to do, anyway, I don't have anything to disclose. So yesterday, I attended a lecture on the coronary anomalies. Pretty significant number of issues really dealt with. So I will not go over everything, and then focus on the issues that need explanation. Okay. So transposition of the great arteries. There are two types. One is that conventionally we used to call complete transposition. Now that, why do we need complete? So most of the people say just the transposition of the great arteries. Another is congenitally corrected transposition. And then also it is called DTGA and LTGA. So because this is one level discordance, ventricular arterial, while congenitally corrected two discordance, atrioventricular discordant connection and ventricular arterial discordant connection. So I will use that 5 minutes for one discordance, and I will use 10 minutes for two discordance. Okay. So transposition of the great arteries, DTGA. Okay. So DTGA. So this is the aorta is not always demalposed, can be level post or posterior position, or even directly anterior. So that's the little bit of problem of terminology DTGA. But as long as you know that and then still use DTGA, that will be fine. Okay? Associated abnormalities, PF4 AST in the newborn, we always need to have, although it can be small. And PDA is usually open, although you need the prostaglandin to open it. And the VST is seen in 20 to 23%, and the left ventricular outflow tract obstruction 25%, aortic arch obstruction in 10%, right aortic arch 5%, atrioventricular valve abnormalities can be seen, and juxtaposition of the atrial appendages seen in about 2.5%. I don't want to go over everything, but I want to call all these three, VST, LVOT obstruction, pulmonary stenosis, aortic arch obstruction, just together, and then make it short. VST and transposition. You can have your VST as a simple punched out hole, just a defect there. And the other not uncommon category is so-called malalignment type of VST. So for instance, this cartoon, this is a TGA. You have your outward septum or infundibular septum here. If we push that outward septum backward, and if we look at in the long axial oblique view, outward septum encroaches on the left ventricular outflow tract, which is a pulmonary outflow tract. Okay? And that is what is called posterior malalignment type of VST. However, malalignment is not just stop there. So this is the beautiful, the 4D angiogram. I had an opportunity to work with Paul Finn for a while last year using the image data. So what you see is in long axial oblique, you have right ventricle, left ventricle, and then you can see that outward septum here, subaortic, subpulmonary outflow tract, pulmonary artery aorta, and the VST apparently below the pulmonary valve. It is double outward right ventricle with outward septum deviated forward. So if you look at this, the uncomplicated TGA, what happened in this case is that the whole arterial trunk and outward septum as a unit are moved forward and rightward. That's how that you have pulmonary valve overriding and outward septum becomes exclusively right ventricular structure. So that is one way. And then, so this is a spectrum. This is a TGA seen from looking at the base. This is a right ventricle, left ventricle, tricuspid valve, mitral valve, and aortic valve and pulmonary valve. So the probe is across the VST. There is a mild overriding of pulmonary valve. A little more the displacement, you're going to have about half of pulmonary valve overriding the VST here. A little bit more now, about 70% of pulmonary valve is now in the right ventricle. Outlet septum is here. And then more, you have this. What is that? So this is so-called TGA DORV spectrum. So all of these TGA variant or DORV, we call that tau-C big malformation. Okay. So here it's a little bit different. So right atrium, right ventricle, left ventricle. You have aorta here. VSD is here. Apparently aortic valve overriding the ventricular septal defect. So looking at this from the left anterior oblique view, you can see right ventricle, left ventricle overriding aortic valve. Here you can see subpulmonary outflow tract is severely narrowed, small pulmonary valve. So what happened in this as compared to TGA happened is that the aortic trunk, the arterial trunks, outlet septum all together as a unit are moved backward and leftward. Because of that, oops. So I need to push the 15, but the 5 minutes, I'm done. So here anyway, that because of posterior displacement, posterior outflow tract, subpulmonary outflow tract is narrow. That is in contrast to the other anterior malalignment, anterior aortic, subaortic outflow tract is narrow. That is the difference. Okay. So here in the inside of the heart, right ventricle, left ventricle, VSD is here. Aortic valve is overriding, so pulmonary outflow tract very, very narrow here. Okay. So putting this together, so this is the en bloc displacement of the great arterial trunk outlet septum, left the rightward and forward, allowing pulmonary valve overriding. Okay. Because of this displacement, you have a subaortic outflow tract narrow. However, if this is another posterior and leftward displacement, making aortic valve overriding and subpulmonary outflow tract very narrow. Just I'm showing you the malalignment makes that one outflow tract narrow than the other type of things. Okay. So that is just a little bit special part of TGA, which was not discussed yesterday. And then I want to go over the coronary artery nomenclature, so-called the Leiden Convention. So this was introduced in 1983. Okay. So what it is that here from the non-coronary sinus, looking at the pulmonary valve, see if it is on your left-hand side, sinus 2, right-hand side, sinus 1. I always find that in echocardiography and communicating, and then a lot of people are confused. I'm introducing very simple way of doing that. So this is the spectrum of great arterial relationship. So this is the right side, this is left side, this is posterior, and this is anterior, okay? So this is the spectrum of aorta, anterior, either right side or left side. This is spectrum of normal relationship, and then the aorta is posterior. What happened? Forget about the left hand, right hand side. If it is the patient's left side, right side, anterior and posterior, if you think about normal, so this, the one, because that what the surgeon is sitting in non-coronary sinus, but echocardiography is completely opposite side. That's why number 1 and number 2 here is a little bit different. Remembering that all the cases having aorta anterior, this left side, the sinus on the patient's left side is always sinus 1, regardless of it is TGA or congenitally corrected TGA, okay? If the aortic valve is posterior, sinus 1 is that patient's on the right side, okay? It doesn't matter what it is. So therefore, if you look at the echocardiogram or 3D-dimensional imaging, whatever. So for instance, here you have the transposition with aorta rising from here. So you have non-coronary sinus, and this is the patient's left side, observer's right side. This is always number 1. Why? Aorta is anterior. If the aorta is posterior, this side is sinus 2. Okay? So here, in this case, sinus 1 gives rise to LAD and circumflex, and sinus 2 gives rise to right coronary artery. Okay. So here is another one. So here that the aorta is more anterior, so this sinus is patient's left side, observer's right-hand side. This is sinus 1, period. Okay. So the other is sinus 2. Sinus 1 gives rise to LAD, sinus 2 gives rise to the circumflex and right coronary artery. Okay. That's how you look at it. Okay. Okay, that's all about the TGA, and let me move to the congenitally corrected transposition. As we agree, this is combination of atrioventricular and ventricular arterial discordant connection. And then again, aorta typically malposed, but not always. It can be on the right side too. Okay. Associated abnormalities in TGA, about 20-25% VSD. But in the CCTGA, you have more than 50% have the VSD. LV outflow tract and pulmonary stenosis very often seen. Abnormalities of tricuspid valve is universally present, and then abnormal AV conduction is a great issue. Okay, so summarizing this into some unique features in CCTGA. The first three, interestingly, complete transposition or a detransposition is not this case, but the CCTGA frequently occurs in situs inversus. Situs inversus is seen in 10 to 20%, and dextrocardia and mesocardia in 25%, and twisted or criss-cross heart in approximately 10%. Okay, and then in TGA and corrected TGA, right ventricle is systemic right ventricle. So therefore, it's different from normal left ventricle supporting systemic circulation in terms of myocardial architecture and the coronary artery reserve. And then also, because right ventricle is a systemic ventricle, septum is usually bowing toward the left side. That is the difference between normal right ventricle and systemic right ventricle. Next, tricuspid valve, incompetence, and then dysplasia and Ebstein's malformation. We all know that. And the left ventricle outflow tract obstruction. So compromised LVOT dimension because the right ventricle, wait a second. Right ventricle is the systemic ventricle, and then left ventricle outflow tract is squashed. And then, interestingly, in CCTGA, you can have abnormal tissue hanging around in the LVOT and abnormal AV conduction. Okay, so what about situs inversus? One thing you need to remember is very interesting. If your CCTGA occurs in situs solitus, you will have a frequently Ebstein-like malformation, complete AV block, and then sustained atrial arrhythmia and severe tricuspid regurgitation and severe RV dysfunction and cardiac death or severe failure. This is common when it occurs in situs solitus. However, if it occurs in situs inversus, much less. Very interestingly, conduction axis is known to be usual inverted pattern instead of anterolateral node exists. Okay? What about heart position? Mesocardia and dextrocardia in 25% or more. It does have a problem. So this is 3D reconstruction in frontal view. You have mesocardia and dextrocardia. So here lower column is seen from the right side. Okay, what does it mean? So if you have your mesocardia and dextrocardia, surgeons will have a difficulty in get access to the right atrium and the left ventricle, right? And then, if you look at the lateral view, look at this. Inside the levocardia, you have atrial tissue surface quite large. However, if there is a mesocardia or a dextrocardia, available surface area of right atrium is much less. So therefore, your surgery will be much difficult. Okay. So what about the systemic right ventricle? Myocardial architecture and coronary artery reserve, I don't want to talk about. But however, so I will show you this. So this is the basal view of the CCTGA. You have mitral valve, tricuspid valve. This is a pulmonary valve and the aortic valve. As we all know, mitral valve is septophobic, which means that pulmonary valve is engaged in, wedged in, and then pushes the mitral valve away from the septum, while tricuspid valve have extensive septal attachment. It does have an issue. Why? If you have a right ventricular dilatation, automatically you make the chorda tendinate papillary muscle spread apart, making your tricuspid valve easily regurgitant. However, if it is left ventricle is dilated because of septophobic position of anterior leaflet, that effect is much less. Okay? So what it means is that the septophilic tricuspid valve with a chordal insertion to the septum is prone to leak when the septum bows toward the left ventricle. Okay. So here is the interesting case. You can see in the four-chamber view, look at the left ventricle. In systole, you don't have any cavity. It's not hypertrophic, but you lose the cavity. If you look at the septum here, in diastole, it is flat. In systole, septum is extensively bowing to the left ventricle. What it means is that left ventricle ejection fraction of 78% is significantly due to septal bowing into the left ventricle. So that's why what I'm emphasizing here, in CCTGA, look at the septal bowing carefully. Your ejection fraction number is very different from usual heart. Okay. So two issues related to septal bowing toward the left ventricle in systole. The first, RV and LV ejection fraction do not represent the systolic function. The second, tricuspid valve leaflets, as we discussed, are not able to oppose properly in systole, causing tricuspid regurgitation. So therefore, tricuspid valve regurgitation in CCTGA, not necessarily primarily tricuspid valve issue, not infrequently. One means that even if it is normally developed, because of annular dilatation and ventricular septal bowing, tricuspid valve can leak, not necessarily due to dysplasia. Ebstein's malformation, yes, of course, is frequent, but however, Ebstein's malformation also different. So this is a usual Ebstein's malformation. This is Ebstein's malformation in CCTGA. So here in the usual, you have your septal leaflet vestigial and displaced. Posterior leaflet also is significantly displaced and then vestigial. Anterior leaflet typically sail-like, right? However, in CCTGA, what happens is that displacement is only minimal, septal leaflet not very hypoplastic, anterior leaflet not large. To summarize that, Ebstein's malformation in CCTGA, atrialized right ventricle is not thin and is usually not large. Severe deficiency of septal leaflet is uncommon. Posterior leaflet is often not displaced, and anterior leaflet is usually not sail-like in most cases, and is more frequently associated with VSD, and then not seen in situs inversus. There is a literature, I do not know what the logic is, but it is the literature says situs inversus has is not associated with Ebstein's malformation. Okay. So next is LVOT, obstruction. So there are many different ways. Posterior deviation of, actually, if it is a levocardia, anterior deviation of outlet septum, and aneurysmal tissue in the membranous septum and other things, or others. So what I want to show you is this. In the long axis, the view, you can see left ventricle, right ventricle, and then this is the mitral valve, and this is the pulmonary outflow tract. You can see there is subpulmonary tissue tag hanging around, right? So here in the MRI picture, you have the same picture. So this is pretty exclusively, almost exclusively in CCTGA. In complete TGA, you usually do not see that. And the next one is this. So this is a basal diagram of normal heart. Tricuspid mitral valve, aortic valve deeply wedged, and pulmonary valve here. In CCTGA, this is mitral valve, tricuspid valve, and pulmonary valve and aortic valve. So yellow is atrial septal plane, and green is ventricular septal plane. As you know, normal heart has the atrial and ventricular septal plane offset because of the engaged position of the aortic valve. That is normal offset. In CCTGA, offset is on the opposite side. It does have an issue. So what is that? So in normal, left ventricular pressure is high. So septum is always pushed to the right ventricular side. Therefore, subaortic outflow tract is not compromised if it is not associated with additional disease. But however, in CCTGA, if the right ventricular pressure goes higher and higher, the septum can push into the subpulmonary outflow tract. You can have a subpulmonary obstruction, a sort of dynamic. Okay? And then finally, abnormal conduction. So here that most frequently literature is saying atrioventricular septal malalignment. that should be corrected. It's not necessarily malalignment. What I mean is that, as I explained to you already, in normal, atrial septum and ventricular septum, there is offset attachment, right, of the alignment. And CCTGA, because pulmonary valve is wedged in, you have atrial ventricular septum malaligned. So look at the AV node here, red here. If here is normal, this offset attachment does not affect the distance from AV node to underlying ventricle. Okay? Therefore, AV conduction axis comes to here. However, here that if your offset is on the opposite side, what is that? AV node is not able to find the ventricular septum. Therefore, it finds another AV node, so-called anterolateral node or the anterior node, and then conduction axis goes along the anterior aspect of the pulmonary valve to reach the ventricle, okay? So this is the one. And then the other is that in CCTGA, membranous septum is known unusually large in the majority of cases. Because of this, conduction is not able to find the connection to regular AV node, okay? So therefore, this is the final drawing. AV node, you have conduction axis this way, and then open the left ventricle, you have conduction, the AV node very high, anterolateral, and then you have a conduction along the pulmonary valve to reach it down here. So conduction axis is never posterior inferior. Very interestingly, if we have your left ventricle outflow tract obstruction, your offset attachment is less. Therefore, regular AV node can find the pathway to the ventricular septum. Surprisingly, in situs inversus, they say usually conduction axis is unusual, not following the rule of CCTGA. I do not know the logic about that, but that is the observation is. Okay, so anyway, coronary arteries following the left ventricle. Don't want to go over too much. So to summarize it, unique features in CCTGA, there are many, many, many. So you should look at very carefully all about this when you really look at the specimen or the imaging. Thank you very much for your attention.